Hello, my name is Samantha Benjamin. Dr. Iris Gibbs served as my research mentor, and our project focused on health equity in radiation oncology. As you may know, cancer is the second leading cause of death in the United States, with an estimated 2 million new cases every year. It is commonly known that racial disparities exist in screening and delivery of care and advanced imaging. These disparities lead to adverse health outcomes for minority cancer patients, and the differences seen between minority and white patients remain when socioeconomic status, education, and geographic location are considered. To address these differences, we hypothesize that modifiable barriers will be identified for treatment delays, completion rates, and differences in the utilization of advanced imaging for patients who received radiotherapy at Stanford Cancer Centers. Our goal is to analyze treatment modality, treatment intent, treatment delays, and correlate these parameters with demographic and socioeconomic factors, including race, ethnicity, gender, age, and social determinants of health, such as zip code, treatment department, and insurance type. We will then propose health equity metrics to guide equitable care in radiation oncology. To this end, we performed cohort analysis to establish pre and post COVID baselines using patient data from January to June of 2019, as well as patient data from January to June of 2022 for patients treated with radiotherapy at Stanford Cancer Centers. Our preliminary results suggest that there are differences in the utilization of advanced treatment techniques based on treatment department and insurance type, also referred to as payer. To provide some background information, Stanford Cancer Center treatment sites include Palo Alto, South Bay, Pleasanton, Turlock, and Castro Valley. As depicted in Figure 1, the incidence of cancer in Northern California is greatest in Turlock. Unfortunately, we were not able to analyze any patient data from Turlock, but we plan to do so in our future investigations. We did, however, analyze data from Palo Alto and South Bay in this phase 1 of our study. Palo Alto generally has a higher median income when compared to South Bay, which is why we were interested in knowing if there are any differences between these two Stanford treatment sites. For the purposes of analysis, treatment techniques were categorized as conventional, advanced, and other. I will just mention a few of the techniques that make up each category. Conventional treatment includes the use of three-dimensional conformational radiotherapy, whereas advanced treatment includes intensity modulated radiation therapy, volumetric modulated arc therapy, stereotactic body radiation therapy, and stereotactic ablative body radiotherapy. The other category includes reflexion, which is biology-guided radiotherapy, MRI-guided radiotherapy, brachytherapy, and intraoperative radiation therapy. We categorize insurance types as private, Medicare, Medi-Cal/Medicaid, and other. For our 2019 cohort, we analyzed 1,979 treatment courses, and for our 2022 cohort, we analyzed 1,875 treatment courses delivered between January and June of their respective years at Stanford Cancer Center treatment sites. As seen in Figure 2, our payer or insurance type analysis revealed that in 2019, more Medicare patients received advanced treatment when compared to other payer types. However, in 2022, the number of Medicare patients receiving conventional versus advanced treatment seemed nearly equal. Our data also revealed that relatively few patients with Medi-Cal/Medicaid are treated at Stanford. But this is consistent with the demographics, considering that most patients around the area have private insurance or some other form of insurance. Another trend we observed, this is depicted in figure 3, showed that in 2019, there were relatively no differences in patients given advanced radiotherapy at Palo Alto when compared to South Bay, with 48% for Palo Alto and 47% for South Bay. However, in 2022, a difference was observed for patients receiving advanced treatment for the two areas. We saw 55% receiving advanced treatment in Palo Alto versus only 39% receiving advanced treatment in South Bay. And if you remember, I mentioned earlier that South Bay generally has a lower median income when compared to Palo Alto. Still, we are uncertain if the COVID pandemic and the resultant delays in elective surgeries may account for the differences as seen in 2019 versus 2022. And so we were not able to form any concrete conclusions about what this data suggests. And so we plan to investigate this further in our future analysis. In the next phase of our investigation, we will analyze the differences in treatment approaches for patients who received radiotherapy at the 3 remaining Stanford Cancer Centers, Pleasanton, Turlock, and Castro Valley, based on race, ethnicity, socioeconomic status, insurance type, and language barriers. Once we identify the strongest correlates for barriers to equitable care, we will then leverage machine learning models to assist in clinical decision-making and address any deviation from the recommended standard of care. Lastly, we aim to use real-time electronic health records and navigational services to address the social needs of patients. For example, provide transportation to and from appointments if we identify that this is an obstacle for patients getting in to see their getting to their appointments. And now I would like to conclude my presentation by saying a very big thank you to Dr. Metter and all the work he did to improve the health of marginalized communities. I'm very grateful to be a part of the effort to help eradicate health disparities seen amongst minority populations. Thank you for your time, and thank you for considering my presentation.